Over the last 30 years, remarkably little has been done to document the history of financial, therapeutic, and operational policy with respect to addiction and behavioral treatment. As part of our mission, C4 has developed a series of films capturing this important oral history. Dr. Bob Lynn is an internationally recognized lecturer, researcher, and clinician in the field of counseling psychology and substance use disorders. During the past half-century, he has held leading positions in state government, addiction treatment, clinical settings, employee assistance programs, and has worked as a professor in several universities. He is a board-certified licensed professional counselor and senior fellow in neurofeedback practice, and a recognized expert in family and behavioral therapy. His major research focuses on issues related to treatment outcomes. He may be best known for his development of methods for the assessment and placement of clients and developing client-centered care-coordinated treatment systems focused on research and outcome data in the United States, Europe, and the Middle East. Dr. Lynn works as the Chief Clinical Advisor for the Levinson Foundation, as an affiliate at the Rutgers Center of Alcohol and Substance Use Studies, as Director of the International Program Development for C4 Recovery Solutions, and as CEO-founder of the Addiction and Behavioral Health Alliance, LLC. Bob also works as Clinical Director for the National Council on Alcohol and Drug Dependence and for the New Jersey Juvenile Justice System Adolescent Evaluation and Treatment Project.
So in 1969, I was an intern at a hospital, psychiatric hospital, when we still had psychiatric hospitals in New Jersey, and I was told that I had to interview for a drug and alcohol program. Actually, it was more of a drug program, and you have to understand the entire context. In those days, there were very few programs. So this was one of the real early programs, and most of these programs, there were really two things happening in the field. On one end, there was the group that came out of Synanon. Synanon was a therapeutic community in California,
Right.
and where people were actually had a town, and Santa Monica, and they would live there their entire lives. They had schools and gas stations and everything else, and there was a big split. There's a lot of people who left there at one point, and it's an interesting story as to why they left. These were people who were able to give up heroin for the most part and other addictions, and they were told they had to stop smoking because the Chuck Dietrich, who was the person in charge, was told by his doctor he had to stop smoking, and he was a not less than fairly autocratic leader, and if he had to stop, then everybody had to stop, and then a high percentage of the people left the next day. They ended up in the community developing these therapeutic communities. There was another group that came out of basically out of AA and out of the alcohol group, and they were developing their own programs as well. Alcohol and drugs were very separate. They weren't even considered the same under the same umbrella. Matter of fact, on the state and federal level, there were different organizations, different actually systems that dealt with both. So the group that I was interviewing for was one of the fellows who left Synanon, and a few ex-priests. Nobody else wanted to deal with drug addicts in those days, and this was but I was told I needed to interview, and they said to me, Bob, do you know anything about drugs and alcohol? And I said, well, I can roll a joint with one hand while driving, and I dropped acid several times with Timothy Leary. They said, well, that's the best we have. So I was hired, and that's that's how I began. And they said, look, part of our orientation is that you show up with your luggage, and you stay here for a while, and we do an orientation that way. That's how you learn the so-called therapeutic model of the day. I showed up with my luggage, and it was half a learning period, and half a intervention of sorts, and that began my baptism by fire into the field. And what I experienced in those days was the most bizarre, at least retrospectively, Jim. And I don't want to use the word treatment, but certainly the most bizarre system that you can imagine. I mean, I can tell you stories of a young man that sticks in my mind, where they shaved his head except for the middle, where they left the big clump of hair, put a big bow on him and a little mini skirt. This is a young man, and made him beg on his hands and knees for 12 hours to please let me stay in the therapeutic community because he had a minor infraction. And then they left and they kicked him out just looking like that. They would be screaming at people. They would be doing all kinds of, making people wear these signs that were just devastating. And then if you did make it through the gauntlet and you got to the end, then as a reward, they would take you out and get you drunk. Now, I know that sounds kind of bizarre, but that's what they would do. And they called that getting your wings. So that was where I started in the field. And it was kind of like, from there, I've had a long, strange trip, if you will. By this time, I've done just about everything you can do in this field, and I began to do work as a sociologist in that point, and began to do research, and I did some of the early outcomes work in 1972, 73. I published probably one of the first outcomes that helped, with a group called Drug Abuse Treatment Information Project, one of the first outcome studies, and I became, from that day on, totally interested in, science and what makes sense in treatment. So that was the early 70s, and I was working for LEAA, Law Enforcement Association, and that was doing research, doing field study. Methadone maintenance had just come into play not too long before that, with Dole and Nicewander, who were the folks who introduced methadone. And
How did they do that?
well, they began with methadone originally was being used for other purposes, and particularly for initially for alcohol, but then it had morphed into a maintenance drug for those who were using heroin, because it was has a long half-life, and it was really a good way to both detox and or develop a lifestyle on methadone. So you had the methadone programs. So MAT is not new. Although some people think it had started yesterday, and there's a lot of research. And then you had the therapeutic communities, and then you had the what was called the Minnesota model, both basically 12-step oriented treatment programs, mostly based on AA, even though AA was never, designed to be a treatment program, and for the most part, Tradition 8, which is the one that says that AA would not be professionalized, I'm paraphrasing, that was fairly ignored as treatment programs began. Some treatment programs began to become, in fact, pseudo meetings, if you will, and that evolved up until today. So you had these three different factions. You had the therapeutic communities for drug addicts. You had the Minnesota model for alcoholics, and you had the methadone maintenance programs for medication-oriented treatment. And that's what was going on. And I quickly morphed out of all of those and began to do a lot of research. From the research perspective, I was publishing, and then I moved into a segue into AT&T, where I was their head of their employee assistance program. We had 1 million employees, and I had 90 therapists. And that's how we ended up with all the baby bells kind of spun off and became, what we have today, all of the different phone companies. But at that day, in those days, it was one phone company. And so I stayed there, and that was a great place to be. We had places, I had offices around the world, basically, and it was at the same time I was working with the government and working with particularly local government and as an advisor and doing things like that. I was at Rutgers University doing research there. So I've always been a multitasker, and I was assistant to the commissioner of health for a while in New Jersey. So I was bouncing around a whole lot. I was a professor, and just having a good time. But being a scientist and a clinician at the same time, because I have dual degrees. I have a clinical degree, and I have a research degree, which made me kind of an odd duck in the field. So I was interested in the clinical work, but I was also interested in, why do we do what we do? What makes sense? How do we know? And I've been asking that since the early 70s. I'm asking that today because we've never answered those questions, you see. And, in fact, one might suggest that little has changed. I got involved with C4 and began to do a lot of international work, working with treatment programs in Lebanon and Palestine and in Turkey, in Jamaica, we worked all over the world, and mostly developing different, supporting indigenous folks and trying to understand how we can add value to what their challenges on the ground. So I'm coming up, by the way, on my 50th year. I'm completing my 50th year in the field, and on some level, Jim, I've people ask, are you burnt out? Are you cynical? And I don't think I'm either one of those, but I do think I'm a pretty serious Don Quixote, and so I'm much more of a windmill fighter than I am a cynic, because I believe, and I have this sense that if you can balance research, outcomes, and compassion, if you have all of that, then you can provide quality care. But I must say, and I mean this with the deepest respect for those who've come, all the unsung heroes who've brought us to today, we still don't have any system of providing treatment in the United States, or probably maybe anywhere in the world, that makes any sense in terms of science. Because treatment has not kept pace with medical science. It's lagged behind for many different reasons, and we can discuss those in detail. But the reality on the ground is that if you have, if you need, someone very close to me came to me recently and said, I need treatment. Now, I've been in the field for almost 50 years, Jim, and you'd say, it wasn't a matter of finances. I know enough people that I can get, I can work that out. And I'm saying to myself, after 50 years, I should know where to send her. I had no idea. What standard would I use? How would I know? There isn't a single comparable outcome. We have no idea what works and what doesn't work. We have no idea I mean, maybe some, I'm not saying things don't work. I'm saying we don't know. I mean, it's a stab in the dark. Outcomes have been mostly for promotion, and if you read the big book of AA, there's a lot of wisdom there, by the way, and it's worth the read if you haven't read it. But and there's something in there that says, attraction, not promotion. I don't know if you're familiar with that, but that's never happened. It's always been promotion. It's always, for me, it's been a matter of taking a lot of square pegs, banging them into round holes, and hoping they stay round, but they all pop out and become square again. I think. So we have this massive field where billions of dollars are being spent continually, and I think there's some change going on, although I think it's happening slowly, and not, well, at least for me, as I get old, I like to see things happen a little faster so that I can experience them. But but in fact, other than some of the real bizarre, unethical things that were going on, 50 years ago, not much has changed. Not much has changed in the field. I mean, it's we don't have benchmarks, we don't have baselines, we don't have we don't know what, we don't even have a shared understanding of recovery. We don't have a lexicon that makes sense. People complain about stigma, and I think stigma is a really important thing to address. But I think more stigma has come out of the treatment field than has come out of the public, because we talk about if I, after 50 years, can't decide how to treat a loved one and have no criteria to do that, imagine a lay person who is desperate because their son, their daughter, their husband, their wife, their whatever are experiencing the need for treatment. People are mortgaging their homes, Jim. People are doing everything they can to put their loved one in treatment with the expectation that there'll be change, and there's no way to measure that. And I'm not saying that people don't get well. Please, let me be really clear. I'm saying we just don't have. It's a stab in the dark, is all I'm saying. And everybody has this. Knows somebody who got well. Okay, and they generalize from that. But that doesn't work for me. If you needed a serious operation, Jim, you would, and your doctor said, "Well, it worked for my uncle. It should work for you." I'm not sure you would. You'd be really happy about that. What happens is, it's like going to the doctor and saying, "Hey, doc, I got a problem. I got an itch right here," and the doctor says, "Well, we'll cut it off over here." And you say, "Well, why?" Well, we do that, and it takes care of the itch. So it's always bigger, better, more. Let's keep people longer. Let's give them more, and we know that produces often diminishing returns. And then we say, look, you go back to the doctor and you say, hey, for another reason, and you say, "Doc, I'm not feeling well." And the doctor says, "Take this medication." And you come back 2 weeks later, and you say, "Doc, it's not working." The doctor says, "Take more." And that's what we do. We say to the addict, "It didn't work, do it again. Do the same thing again that didn't work. Go back," and you go back 2 weeks later and you say, "Well, it's still not working." And they say, "Well, that's because you're taking it wrong." So not only do we give more of the same, but when it doesn't work, some people tend to blame the patient for the failure of the program, for the failure of the system. Now I find that to be just something that's very difficult for me to deal with. In my mind, Jim, I don't. My outcome, at least from the beginning, is meeting the patient where they present and treating them with a balance between what they want, ethics, compassion, and research. That's where I work. So for me, there is not one way to do treatment. There is not one pathway. There is not even one outcome. And for some people, it's abstinence, because that's what they must have to have a quality of life. For some folks, it's a different pathway. For some people, it's medication. For some people, it's finding a new place to live. In my opinion, folks don't get well because of CBT, EMDR. I mean, I've never met an addict in all these years who said, I'm got great sobriety based on my CBT. What I do know is that if you can deal with what I think, transcends so-called clinical issues, and I'm saying this as a therapist, as a board certified therapist, I'm saying that what's really important are things like jobs, housing, child care, access, to those stakeholders in the community, such as medical care, such as, people who, that can support sustained recovery. Because sustained recovery does not take place in a treatment center. You don't develop, maybe, I consider the first part of treatment, when you get in treatment, to be acute care stabilization. I want people stabilized and out as quickly as possible. Treatment needs to take place in the community, in real life. And it needs to be sustained, and it needs to go on for a very long period of time. Because we say we have it's a chronic disease, we treat it like it's acute with acute care, and then throw people out into the back where they came from and expect them to be well. Yeah. It doesn't make sense to me. So for me, it's all about developing a healing community, as opposed to developing a better therapy. We talk about an opiate epidemic, and people say, well, we need to give people more access to treatment. Why would you give people more access to treatment if you don't know if the treatment works? I mean, what kind of solution is that? I mean, it doesn't make sense. What I want to give people access to are those kinds of services and stakeholders and systems that can support sustained recovery. And when I say recovery, that can mean, I don't have one definition of what recovery is, or one point in recovery. And I know at least for myself that I really appreciate this opportunity to have this discussion with you. But I would say in all candor, Jim, that if we have it a year from now, it would probably be a very different discussion, because my thinking is not static, and I'm learning from people every single day, mostly from my students. I've been a professor in a couple universities, and I have a wonderful affiliation with Rutgers in New Jersey, which is one of the premier research and training institutes in the world. And so I'm learning all of the time. So if we do this a year from now, I'll probably be looking back at this interview and saying to myself, well, Bob, it seems that your thinking has changed again. And I think that's really important. So Jim, I think if we're going to talk about quality and quality care, I think it's important to level the playing field when we speak. And I think although I don't think that addiction treatment has kept pace with medical science, I think it's the over-focus on addiction treatment and the quality of care without looking at the entire behavioral health spectrum, I think is unfortunate, because we haven't had any more research and good outcomes in psychology than we've had in addiction treatment. So I'm not sure that there is much of what happens in the psychological session, in the psych session, is more credible than what happens in the addiction section. So I think that's important. And why is that important? Because I think the focus needs to be through a wider lens. And I think the arbitrary separation between one's psychology and one's addiction, doesn't make a whole lot of sense for me. So I think we need to bring them together under the behavioral health umbrella, but at the same time, we need to have similar standards. We can't have higher standards of care in the sense of wanting the justification for outcomes and research than we have for other psychological protocols. So for me, you know, it's a quantum leap when you say that we're doing evidence-based care because there's some evidence that something else worked somewhere like CBT and we're using it, so we're not doing evidence-based care until we have real-time evidence that we're doing makes sense. What I want to be, my dream is that when you present for treatment, I'm able to have enough data to say, when all the people that look like you, have similar backgrounds, presented with the same challenges, when we did A, B, C, D, E, we really had good outcomes. So let's start there. And then as your needs change, because for me, assessment is an ongoing process, we're light at the front end and much more intense as you move through the care continuum, because that's when we really learn about you. Because at the front end, I mean, you're anxious, you might still be under the influence, and at least in some ways, you may not even want to be there. But we learn a whole lot about you as you move through the care continuum. That's when we need to be doing continual assessment, and as your needs change, provide those protocols, that care that makes sense to meet those needs as they evolve. If we do that over a period of time, then we know the outcome we're going to have is going to be positive because because it's driven by your needs, not the programs.
Yeah.
So for me, that's my dream, to see that happen. I would like shorter inpatient stays and longer. I put my money into continuing care, not once someone is stabilized, get them out and let's get them moving, and once we can give them the traction that makes sense. But that takes a whole different paradigm. It's a different way of looking at the addict. It's a different way of looking at treatment. And change doesn't happen overnight. So like I said, I think there is some movement sensations, but I think that it's going to be a while until we see a wholesale change in the system. I don't want to cast a totally negative spell on these unsung heroes who are out there working really hard every day. What I will say though, Jim, is that for the larger conglomerates, those who are the investors and entrepreneurs of providing care, there is no incentive for them to change. If you're raking in tons of money, your ROI is perfect. Why do you want to hear from somebody who's telling you that you need to do treatment differently, or treatment needs to change? And as you said, outcomes. I believe in outcomes. That outcomes are important. But for me, research is first. And the why is research first, because I don't want outcomes on treatment that is substandard. That doesn't make any sense. So outcomes alone are people who talk about their outcomes. Outcomes don't make a whole lot of sense to me unless their treatment is based on research. So let's start there. Start with the research, and then the outcomes can inform the new research. So you have this loop where you have the research, then we collect the outcomes based on the patients that we treat. We put that into a portal, and then we take that data and we develop the algorithms that can feed back to the clinician, so the clinician can provide better care. We can do that on the clinician level, and we do that on the program level. So we can evolve the program. So you wouldn't want your doctor doing, if you needed an operation and your doctor said, I got some things I was doing 20 years ago that I really like, and that's what I'm going to do. You'd say, well, doc, hasn't there been any change in 20 years? We can do things, less invasive, shorter hospital stays, less medication. He'd say, 20 years ago this worked and it'll work today. You don't worry about it. that would be, you would say, wait, I want a new doctor. But that's where the treatment field is at today. It's not just 20 years, sometimes it's 30 years, and sometimes it's 40 years. So for me, I want to do treatment based on today's needs. I want to take the best that we have in terms of research, experience, which is outcomes, and compassion, because like I said, if you don't have the compassion, I want to include all the things that we know are important, which includes spirituality, and I can go off on that for a while if you wanted, but that includes the broader context of a patient's life. And I use the word patient. Some people like client, but I like patient. Hookers have clients. I like I like patients because I think that's respectful. But we ignore the broader context, not just family, but everything that makes up our lives. And I think that all of that needs to be rolled in, and it's respect and love and caring and research. Somehow or other, you got to put that in the stew, mix that up, and then it comes out, as genuine, as authentic. So it's not, I'm not a cold stone research oriented person that says, we got to do this by the book. What we got to do is do it by your book, not mine. I've been fighting these windmills now for almost 50 years, and and sometimes I like to reflect on, I've been asked, what is it that you'd like to be thought of? What is important to you? When people think about you, what would you like them? Is it a book you wrote, an article you've written, a new philosophy or therapy that you've developed? None of the above. What's really important to me, I want them to say, this man was authentic, he cared on a very real level, and he paid it forward. And I pay it forward by not just doing 12-step work, although I think 12-step work is real important. For me, it's about mentoring. It's not only helping the struggling addict, but the struggling therapist, the struggling child, the struggling adult. It doesn't really matter to me. To me, it's about paying it forward. I want to be thought of as the guy who was there when the phone rang. I was there when the call came. He stepped up, and he stepped up genuinely, and he followed through. That's how I'd like to be seen, and that's I want to be seen as an authentic human being who really cared. And to say that that's where I'm at right now would be less than humble, because that's what I'm really saying is that's what I strive for. And it's not for me to say, it's for you to say, Jim. But for me, it's just a goal. For me, as I said, I see myself as just another struggling pilgrim with all the fallacies and all the struggles and challenges of what it means to be a human being. And I don't apologize for those. Actually, I relish in those, because it's those struggles that allows me to grow, allows me to get better, allows me to be a better husband, father, to be a better friend. So if you can say to me, this man really cared about me. This man was genuine.